Thank you. Ladies and gentlemen, now it's time for the lighting of the oil lamp, signifying auspicious start to our proceeding. Kindly remain standing. We would like to invite the following dignitaries to please join us and brighten up this wonderful event. The Secretary, the Additional Secretary, Public Health Services, Dr. Lashmi Somatunga, WHO Public Health Administrator, Dr. Shalala Amadova, the Director of Health Promotion Bureau, Dr. Ranjit Batuantulava. We are also delighted to invite Director Quarantine Unit, Ministry of Health, Dr. Monica Vijay and Response Unit, Dr. Samindi Samarakot, Consultant Committee Physician, Quarantine Unit, Dr. S. Dilhan Samarasekara, Consultant Committee Physician, Unit Thank you all. Now I would like to invite the following dignitaries to the head table. We are delighted to have them join us on the stage. Our chief guest, the Additional Secretary, Public Health Services, Dr. Lashmi Somatunga, WHO Public Health Administrator, Dr. Shalala Amadova, Director of Health Promotion Bureau, Dr. Ranjit Batuantulava, Consultant Committee Physician, Unit Head of the Risk Communication Unit at the Health Promotion Bureau, Dr. Amanti Bandasena, Consultant Committee Physician at the Quarantine Unit, Dr. S. Dilhani Samarasekar. Ladies and gentlemen, now I would like to welcome Director of Health Promotion Bureau, Dr. Ranjit Batuantulava, to deliver the opening address. He will take this opportunity to provide his welcome remarks and outline the objective of this event.
Good morning. Dr. Lakshmi Somatunga, Additional Secretary Public Health Services, Ministry of Health. Dr. Shalala Ahmadova, Public Health Administrator, WHO Country Office, Sri Lanka. Dr. Amandi, Dr. Dilhani, Dr. Vinyari Ratna, and all the consultants, development partners, friends. Thank you very much for accepting our invitation and being here today. On behalf of the Ministry of Health, Health Promotion Bureau, I welcome all of you to this important event today. Risk communication is one of the very important factors we all public health specialists, public health practitioners have to face these days. Sri Lanka has a very remarkable track record when it comes to public health events, public health achievements, public health indicators. Also, we faced a lot of natural emergencies, disasters during the last several years. Asian tsunami, then some man-made disasters in the country, internal migration in the country, and one of the most remarkable, the COVID pandemic, taught us the importance of talking, selection of words, and not selecting some words. These are the principles behind risk communication. Since 2017, when the WHO IHR external evaluation started, both the quarantine unit, EPID unit, and the Health Promotion Bureau was entrusted of making changes and changing some system events related to risk communication. And we know it's quite a tough task in Sri Lanka to do changes in the system. One of the important things in both 2017 and then subsequent evaluations revealed that Sri Lanka, we need to have document level supporting and policy level support for risk communication. Therefore, this task was really important one for all of us in the country. With that, all of you, I believe more than 60 stakeholders, more than 60 partner agencies participated during last 1.5 years in the development of this guideline. The main objective today is to mark the launching of this guideline. But of course, the most important matter is that we start practicing at least some of the guidance given in this guideline, which we already been doing in our day-to-day life. This document has been presented to you with one of the most simplest manners, and it is adaptable to each one of your situation, each one of your risk communication activities. So feel free to start using this, referencing this, and of course this document will be reviewed and edited in 2 years' time. So all of you, I would like to kindly wish to extend the request. Had you come across any places where it needs to be changed, please let us know. And this will be a continual process. Every 2 years, this document will be reviewed and updated. And another objective today on this document is to prompt and suggest you to keep on starting and using and expand using of modern technology into your day-to-day risk communication activities. Health Promotion Bureau is proud to be using some of the modern technologies available for communication. Some of the, actually the cover page of this document also AI generated by a registrar in the Health Promotion Bureau, which is a lovely thing to have that expertise, and we need to develop and give the opportunity for those expertise. And we are planning to distribute this document. Of course, each one of you will get a hard copy today, but we are planning to distribute it through online QR code based methodology. So for modern risk communication, using of modern technology also very important, because we will be faced with the task of handling on the spot risk communication with the modern communication platforms like Facebook and other social media. So I believe this guideline developed by Health Promotion Bureau with the contribution of all the stakeholders listed in the book and the to be used as the initial guidance for emergency related risk communication in the country. And your feedback on the use and your suggestion on the changes are the most important factors to make this a success. Ladies and gentlemen, once again thanking you for your presence here today. I wish to conclude my talk. Thank you very much.
Thank you, sir. Next, I would like to invite our distinguished guest, Dr. Shalala Amadova, Public Health Administrator from World Health Organization, to share a few words. Thank you.
Good morning everyone. Dr. Lakshmi, Additional Secretary of Public Health Services, Dr. Ranjit, Director of the Health Promotion Bureau, and all participants of this meeting. I welcome you to this meeting, launching of the National Risk Communication Strategic Plan for Public Health Emergencies 2023-2025. Risk communication is an integral part of any emergency response. It is the real-time exchange of information, opinion, and also advice between experts, community leaders, or officials, and the people who are at risk. When the emergency strikes, rumors or fake news have immense potential to create panic and distrust in affected communities, and in doing so, to impede public health interventions. People need to know what health risks they face and what actions they need to take to protect their health and lives during public health emergencies. Accurate information provided early, often, and in languages and channels that people understand, trust, and use enables individuals to make the choices and take actions to protect themselves, their families, communities from these threats. It also allows the authorities and experts to listen to and address people's needs and concerns, so that the advice they provide is relevant, trusted, and acceptable. Risk communication was initially used to address the environmental hazards. Now risk communication is being used in almost all global outbreaks. World Health Organization has developed the manuals, training models, guidance documents related to the emergency and also risk communication, which are based on the expert opinion or lessons learned from the major environmental disasters or disease outbreaks, such as severe acute respiratory syndrome outbreak in 2003 and H1N1 influenza pandemic of 2009. Recent public health emergencies, such as Ebola virus disease outbreak, the emergence of the Zika virus syndrome in 2015-16, and multi-country yellow fever outbreaks in 2016, and of course the COVID-19 pandemic, have highlighted the major challenges and gaps, how risk is communicated during epidemics and other health emergencies. Important gaps include taking into consideration the context, the social, economic, and political context, which have the impact on the people's perception of risk and also their risk reduction behaviors. Guidance is needed on the best approaches to strengthening emergency risk communications capacities and also sustaining them for potential health emergencies. Risk communication is one of core functions WHO member states must fulfill as signatories of the international health regulation. Risk communication is also part of the many global and country preparedness plan and also part of the pandemic influenza preparedness framework. In member states across the Southeast Asia region, risk communication capacities have been evaluated either as part of the ICHAR joint external evaluation of the core capacities or through other mechanisms like the after-action reviews following the health emergencies. The findings from this evaluation have formed the basis of the regional risk communication strategy for public health emergencies 2019-2023. Today it is my privilege to address you as we gather to launch a vital initiative, the Risk Communication Strategy by the Minister of Health. This strategy represents a significant step towards promoting public health and also well-being of the people in the country. The Health Promotion Bureau is the focal point for risk communication in the Ministry of Health. It is expected that further strengthening the system through streamlining risk communication and establishing formal communication guidelines and procedures between diverse stakeholders. In conclusion, the risk communication strategy launch is a significant milestone in our collective efforts to promote public health in Sri Lanka. This strategy is a commitment to the people of the country, but the success of this strategy depends on all of us, the government, healthcare professionals, the media, the public, the partners, all of them working together. Thank you and let us embark on this journey together for a healthier and safer Sri Lanka. Thank you very much.
Thank you, Dr. Shalala Amadova. Ladies and gentlemen, now it's my privilege to invite the chief guest of this morning, the Additional Secretary, Public Health Services, Dr. Lakshmi Somatunga, to address this gathering.
Ayubowan. Very good morning. Our director, Dr. Matwantu Davi, Health Promotion Bureau, and representative from our one of the strongest stakeholders, WHO, Public Health Administrator, Dr. Shalala Ahmadova, and all the directors, deputy directors present here, our consultant committee vision, especially the head of this communication unit of Health Promotion Bureau, representatives from academia. I see my colleagues are also here. All the other all other stakeholder organizations, representatives, ladies and gentlemen. Though there's a big event happening in the medical services, which I also have a link because I was the DDG Medical Services for 6 years in the Ministry of Health, but my passion for public health led me to come here. It's a pleasure to be here when you really launch for the first time in Sri Lanka, I think, this very important strategy document, because risk communication is a major component of public health and also a critical tool in disaster or emergency response. And it was evident in the recent past that this was very important during COVID-19 pandemic. And people began to talk about it more than never. Actually, this enables people to make informed information on the effects of, to mitigate effects of hazard. It may be an epidemic, it may be a pandemic, it may be another emerging disease confined to this country, or effects of climate change. So whatever, it is so important, and also to protect themselves, prevent disastrous effects of a hazard. But anyway, this has become everyday life now. Even yesterday when I addressed the National Health Development meeting, talking about Nipah, I had to mention about this risk communication. But with my out of 30 odd years in the Ministry of Health, about 25 years dedicated to public health, I know that those days risk communication was in somewhat in controlled fashion. Nowadays it's different because competing opinions come sometimes, enter into the mix. That does not matter, allowing health professionals to steer the risk communication, because the correct thing should go to the public, and this should be evidence-based, and we can really build trust, because sometimes all our colleagues know that the different communications happen sometimes, even fast during the COVID, but it should not be so. because this is a coordinated action. So now we have a critical tool, the strategic plan document. I know that following a series of consultations, you have done this with the contribution by all concerned and relevant stakeholders. So I am very proud of Health Promotion Bureau, the director and the team. Talking a little bit about Health Promotion Bureau, about 7 years back, I came to inaugurate something else at the Health Promotion Bureau, and I said, look here, please be modern and go digital. And they really absorbed the task, and they showed that they can go digital. And after 5 years from that particular event, I came to inaugurate all online digital communication materials, and very nicely they launched that. They are now modern and going along with the digitalization, electronic way. I'm very happy. Your platform is really now go viral sometimes, reaching good numbers. Please keep it up, and my appreciation goes to the director and the team for doing these marvelous things, because these are our responsibilities to guide the health sector. And after all, nation's health, we have a big responsibility. Whether diseases are happening or not, because we have health promotion. Public health has two components: disease control and health promotion. In the health promotion Bureau plays a vital role, because in the journey of making people's expectation of life, healthy expectation of life, these things become very important. One of such thing is the communication. So I hope that this will build a trust among all our stakeholders, because this is a collective effort, and this will be a real important, valuable, helpful guide to the nation. And as Dr. Bhatwanthabhava said, they are going to review in 2 years' time. That is also, and at least if you can review in 3 years' time, that's okay, because with such a lot of enormous efforts, right? Carefully design one, at least for 3 years, I think it will be valid. But anyway, if you can do it in a frequent manner, it's okay. But I wish that this will be useful and people will utilize this. The guide illustrated in this valuable document will be a real tool for the nation and communities. And your presence here today, from all the stakeholders I can see, your presence here today illustrates your enthusiasm in the subject. I do really appreciate that, and wishing all the very best of the Health Promotion Bureau and all of you. I stop here by saying, Sabbe Satta Bhavantu Sukhitatta. May all beings be happy and healthy. Thank you.
Thank you, Madam. Ladies and gentlemen, the ceremonial moment has arrived to officially launch the National Risk Communication Strategic Plan for Public Health Emergencies, Sri Lanka. This will be available in both hard copies and online format. It is my honor to invite the Director of Health Promotion Bureau, Dr. Ranjit Bhatwanthabhava, and Consultant Community Physician and Unit Head of the Risk Communication Unit at Health Promotion Bureau, Dr. Amanti Bandusena, to present the National Risk Communication Strategic Plan for Public Health Emergencies, Sri Lanka, book to our distinguished guests. I would like to invite Dr. Vinya Aryaratna to come forward and receive the book. Also, Dr. Sampata. Ladies and gentlemen, the QR code will also be distributed as a token among all of you. Thank you, sir. Thank you, madam. On that note, we are happy to announce that the National Risk Communication Strategic Plan for Public Health Emergency Sri Lanka has been officially launched. The next item on our agenda will be overview of the National Risk Communication Strategic Plan presented by Dr. Amanti Bandusena, Consultant Community Physician, the Unit Head of Risk Communication Unit at the Health Promotion Bureau.
Thank you, and a very good morning to all of you. So, thank you very much. First of all, why are we having this National Risk Communication Strategic Plan? So, as we were the strategic plan is an essential component of a strong and resilient risk communication system in any country. And it's needed to optimize risk communication occurring at many levels. We know that it occurs at many levels in different sectors for a wide range of identified issues. But what we really need is to streamline partnership and have active collaboration, so that this will minimize duplication of precious resources and issuing of mixed, confusing, contradictory messages. Then the timely reach of critically important action messages by most vulnerable at-risk populations can be ensured with the implementation of this plan. Building capacities of local communities to proactively engage and respond urgently and positively to health messaging with strong community engagement in crisis situations will be facilitated, together with herd behaviors conducive to risk mitigation through best possible behaviors learned from champions or community leaders in emergency and risk situations. And of course, to streamline and greatly strengthen implementation of all risk communication activities. So the background to this strategic plan is this. This was developed, as has been said, by the Health Promotion Bureau, which is the focal point for risk communication in the Ministry of Health. And this is the first Sri Lankan National Strategic Plan for risk communication for public health emergencies. And we know how critically important risk communication is, as it's a critical tool in emergency preparedness and response. This plan has been developed in line with the regional risk communication strategy for public health emergencies in the WHO Southeast Asian region. Relevant stakeholders, inclusive of development partners, have contributed to this plan, and I'm very happy to see that representation across the board from so many sectors is there. So you all have all played a great part in contributing to this plan. And this is a joint venture in which ownership rests with well-planned, coordinated and timely risk communication and community engagement by all of us, or all the diverse stakeholders. And the timeline for this plan is 2023 to 2025, in keeping with the dynamic nature of risk communication and in keeping with the with lines of IHR scoring system for optimal scoring. Best practices to be promoted through this plan are as follows. Coordination at different levels with collaboration and ownership by diverse stakeholders. So we want active ownership and collaboration, with responsibility being divided among all of us, with outreach to communities and engagement of communities, youth, religious leaders and champions in the community. Then to have social listening systems in place and proactively ready before emergencies. We saw the importance of this with the COVID-19 pandemic. And of course, the continuous use of the risk communication systems established for COVID-19 response for other public health emergencies. Then learning by doing. We can always improve on what we are doing and share and showcase our successes in risk communication, and promoting research and an evidence base for best practices in risk communication. Once again, we all have a very active role to play in this. So what are the areas which we expect to be strengthened through this plan? We would like to have defined responsibilities for staff on risk communication both within and outside the health ministry. Then strengthened and streamlined collaborations facilitated through guidelines and standards of procedures, or SOPs, for communication in risk situations and emergency preparedness, which are developed well before we really do need to put them to use. And of course, a dedicated budget for risk communication, which we have seen to be critically important. What are the objectives of this plan? The general objective is to enable successful mitigation of risk and crisis situations in Sri Lanka through risk communication. The specific objectives are four. The first is to strengthen risk communication systems and community engagement for health risk public communication in Sri Lanka. Second, to strengthen national capacity for proactive and dynamic risk communication. Third, to optimize community engagement in risk communication through identifying perceptions, concerns, and proactive behaviors. And last, to develop inbuilt mechanisms to monitor and evaluate risk communication at all levels island-wide. So this plan is heavily based on the 5 key pillars of risk communication, which is based on the IHR WHO risk communication model. So these are the 5 key pillars: the risk communication systems, internal and partner communication and coordination, public communication, communication engagement with affected communities, and dynamic listening and rumor management. So, since we have all actively contributed to this, I would just like to specifically say some of the key areas in which the support of all stakeholders is really critically needed. So when we consider the support of PDHS, RDHS teams and the healthcare sector, what we would really like to see their support in is incorporating risk communication into provincial, district and divisional level annual action plans. So these were all discussed at the consultative meetings that we did conduct. Then establish a working group on risk communication with key stakeholders at provincial, district and divisional level. Having an emergency response team with at least one risk communication resource member at provincial or district level. And having authorized spokespersons on risk communication at provincial and district levels. Further to this, identifying logistical and financial resources, strengths and challenges in risk communication, and even more importantly, the means of overcoming these challenges. Designating resources, including funding for risk communication. Mapping stakeholders at provincial and district levels, identifying their roles and networking with them. Supporting capacity development in risk communication, documentation of risk mitigation activities for affected populations at district level, and supporting research in risk communication. So these will all help to further build our risk communication system, IHR requirements and all the national requirements to make us a very healthier and proactively engaging nation to develop our health. So considering the stakeholders outside the health ministry, what are the key areas in which we expect their support? Addressing local risk issues identified in collaboration with all relevant sectors. This is critically important. And of course, in developing the standards of procedures for risk communication in emergency and disaster situations. Then external partner networking at all levels. For this, your collaboration and support is critically important, together with availability of resources and funding designated for risk communication. Then again, specific role identification and documentation so that everybody is aware who they can approach, who is a relevant person to do this area when it comes to activities and responsibilities. Then grassroots level officers identified with networking and building capacities in risk communication with conduct of relevant research. We would like research also to be conducted by all stakeholders. So there are a few new aspects which are being focused in this plan. One is accountability to affected populations. We had several workshops with this, and UNICEF, our partner also in risk communication, has played a very supportive role. So I think from the provinces, districts and national level, quite a few of you attended these the workshops also. So this AAP, accountability to affected populations, also features in this plan. And of course, we need to strengthen risk communication relevant to areas given suboptimal attention, sometimes due to these issues being less common. For example, chemical, biological, radiological and nuclear emergencies in Sri Lanka. So we can really strengthen the risk communication in these areas also through SOPs. Even when we consider AMR, that is also an area which we need to give further attention to. So just to give an example regarding the AAP, or accountability to affected populations, what we need as an indicator in this plan is the availability of a document on measures to ensure AAP with quarterly reports on communications to mitigate risk for affected population at district level. Here's just one example which I have taken from the plan. Then, considering all of us, key areas to specially focus on for all stakeholders, we really need to, we have done so much. Each of us has done so much. There has been a big contribution all over to risk communication, especially with the COVID-19 pandemic. I know all sectors, everybody has done a lot of work, but what we really need to do is to strengthen, formalize, and streamline the risk communication system. Then closing the communication feedback loop with communities with systematic response to feedback received through online and offline communication and research. Then special focus on more vulnerable populations, designated resource allocation for timely risk communication, and of course monitoring and evaluation being inbuilt into all activities with good documentation. We all do a lot of good work, but unfortunately sometimes the documentation is not up to mark. So we really do need to focus on this also, especially when it comes to external evaluation. It is critically important, and not only external evaluation, even when we do our work to further progress, to know where we need to go, this documentation is extremely important. So then we come to the JEE, which we had in September this year, or the Joint External Evaluation of the International Health Regulations. So I won't talk much about the IHR. Dr. Dilhani will speak in detail about the IHR. But this risk communication and community engagement is one of the core areas under the IHR, and there are 3 indicators which are taken internationally for scoring. So these scores contribute to our score as a country overall. So this scoring criteria has been modified. And the scoring criteria which was recently applied is much more stringent than the previous criteria which was there, considering lessons learned during the COVID-19 pandemic, when we saw that the whole world, even the developed countries, were actually less prepared than they thought they were for public health emergencies. So on this scoring criteria, one is the RCE system for emergencies. The optimal, the best possible score is 5. We reached a score of 3, considering the resources and work that we have done. So to go to level 4, we need a strategic plan, which is there now, which is reviewed at least every 24 months. That is why, together with risk communication being such a dynamic process which needs continuous updating, to score on the IHR requirement also, we do need to review this plan every 2 years. So to build the system, we have done so many things, just a few things. We have the Technical Advisory Committee on Risk Communication, for which we have multiple stakeholders. We have developed material relevant to system strengthening. There was a plan relevant to COVID-19 as soon as the situation arose. Then there are so many things that we have done to strengthen the system together with infodemic management, which has been really going very well progressively. Then the second indicator is risk communication. Once again, we reached a score of 3 out of 5. And to reach a higher score, we need to monitor daily and get feedbacks daily to adjust the risk communication strategies and infodemic management, focus a bit more on offline sources also, for which your feedback from grassroots level is critically important, together with ground level research, and coordination across sectors and levels of government need to be really further strengthened and streamlined. So regarding risk communication, so many things have happened in the public domain. There have been mass media campaigns with the collaboration of our UN partners. This was a campaign, mass media campaign with UNICEF, where we had TV, radio, print, social media, so many aspects. So these were the TV commercials which went. Then when we talk about where we were and how we have developed in the social media domain, we can see all the spots that have been developed, feedback which is given instantly with social media spots, with the spots, then the monitoring that happens, etc. we can see. Then the third and final indicator is community engagement. Again, we scored 3 on this indicator also. So to further move up to 5, which I'm sure we can move to 5 by the next review in all the areas, we need mapping of active mapping at all levels of all organizations related to community, and collection and analysis of community feedback and social behavioral data at national, intermediate and primary public health response levels. These are some of the areas which we need to further improve on, which we need to work on through this strategic plan. So the work we had done was really greatly appreciated, but what we really need to do is to further strengthen, formalize and streamline this system. So these are some of the things that were done for community engagement during COVID, using interfaith platforms with all religious group leaders involved. Then community engagement and COVID vaccination rollout handbook was also prepared together with Sarvodaya by Dr. Supun's team at Promotion Bureau. So, what are the priority action areas for the way forward? Now, these also came from the final recommendations at the JEE. So, in a nutshell, these are to establish sustainable, robust systems and build capacities in all levels and sectors in risk communication, to develop resources and mechanisms to establish an integrated risk communication system that strengthens strategic utilization of community feedback, social behavioral insights and risk assessments across all tiers, to review and adapt existing structures and processes to integrate risk communication and community engagement together with infodemic management into provincial, district and divisional annual action plans, and to ensure allocation of dedicated resources and establish robust mechanisms for ongoing monitoring and adaptive enhancements. So this is our work cut out for us in a nutshell before the next JEE. And of course, with our 2-yearly review, we would really appreciate all your feedback regarding this roadway and journey. So thank you very much. I will end here. Thank you.
Thank you, Madam. Now, I would like to extend a warm welcome to Dr. Dilhani Samarasekara, Consultant Committee Physician at the Quarantine Unit, who will enlighten us on the topic of international health regulation and their relation to risk communication.
Good morning, Dr. Shalla Amartoa, Administrator WHO, Dr. Anjit Patwan, our Director Health Promotion Bureau, distinguished invitees and my dear colleagues. It's a great pleasure for me to conduct this presentation, and I thank Health Promotion Bureau for inviting me. So as you all heard, this is related to International Health Regulations 2005. So my presentation is on International Health Regulations 2005 and its relation to risk communication. So you know, diseases have no borders. Even though our country is an island, we can get the diseases. Like the avian influenza can come. Fortunately, we didn't get any case so far. But and a lot of the vessels are going here and there, so we can get the diseases. So international travel and trade facilitates diseases fast, like, so we know we got COVID, even though we got a lot of measures to prevent it coming into our country, we got COVID-19. And disease in any corner of the world is a threat to the rest of the world. So world is changing as never before. Rapid population growth and increased proportion of people belong to extreme ages. So rapid expansion of international travel and trade that quickly transport people and goods across vast distances. New microbes emerge and adapt to the environment. So as mentioned earlier, diseases can travel fast. So there are increased risk of chemical, radiation and food hazards. Because of this, the global health security is at risk. So when we consider the past 30 years, we have heard about the HIV/AIDS, Chernobyl disaster, plague, Ebola, Marburg, Nipah virus, yellow fever, anthrax, SARS, meningitis, cholera, chemical disasters, avian influenza, multi-drug resistant TB, and recently COVID and monkeypox. So when we get the history of the international health regulations, cholera epidemics in 1830 to 1847 in Europe paved the way for infectious disease diplomacy and multilateral cooperation in public health. International Sanitary Conference was held in Paris in 1851. So WHO Constitution, they have included about health in 1948. WHO member states adopted first international sanitary regulations in 1951. Initially, there was international health regulations, we called earlier international sanitary regulations. So later on, international health regulations replaced the international sanitary regulations in 1969. So from 1969, IHR was there and it was amended in 1973 and 1981. In 2005, IHR 2005 was introduced after SARS in 2003. So currently we use the IHR 2005. So the purpose and scope of IHR 2005 is to prevent, protect against, control and provide a public health response to the international spread of disease in ways that are commensurate with and restricted to public health risks and which avoid unnecessary interference with international traffic and trade. So you might have seen during COVID-19, WHO didn't ask us to close our borders. The countries on their, they took the decisions and closed their borders. And in the IHR 2005 book, there is the annex, article where if the countries are changing, if the WHO has not recommended, we have to inform them why we got this measure. So in the purpose and scope, there which avoid unnecessary interference with international traffic and trade. So International Health Regulation 2005 came into force on 15 June 2007. That is to ensure maximum public health security while minimizing interference with international transport and trade. And this is a legally binding document. So you must have seen this book and you can download it from the website, and currently the 3rd edition is available. So in this IHR 2005, they have mentioned about the national IHR focal points. In Sri Lanka, this national IHR focal points, there are two, the epidemiology unit and the quarantine unit. So national IHR focal point is the national center, not an individual, because it's in the definition of IHR 2000 book. So it's the center. So as mentioned, quarantine unit and the epidemiology unit are the core national focal points. So it might be accessible at all times, 24/7. So national IHR focal points are responsible for facilitating urgent IHR communications with WHO and other member states, disseminating information to and consolidating inputs from relevant sectors of the government, other important tasks as needed. So there's a guide in the WHO website. So we are always collaborating with the country office as well as through them to WHO Geneva office and other country national IHR focal point as well as the stakeholders in our country. So out of the EPID unit and quarantine unit, the quarantine unit usually coordinate these activities. So the EPID unit is involved mainly surveillance and other related activities. So as you may know, all the public health officers in international points of entry, that is airports and ports, are under the quarantine unit. So what is the importance of risk communication and community engagement in international health regulations? Effective risk communication and community engagement are crucial during health emergencies. As mentioned earlier, this is the RCCE, that is risk communication and community engagement, is there in the pandemic preparedness plan and other global health agendas. So this is a very important area. Risk communication aims at enabling all people at risk to make decisions so as to mitigate the effects of threats such as disease outbreak or other public health events, and so as to take preventive and protective measures. So access to credible, trusted, relevant, timely, accessible and actionable health information plays a vital role in encouraging the acceptance and adoption of life-saving interventions. So there are 4 methods of monitoring and evaluation of international health regulation. State party annual reporting, that is a mandatory thing. After action reviews, simulation exercises, joint external evaluation. As mentioned earlier, we conducted joint external evaluation in 2017 and the second one in 2023. Recently we completed the second joint external evaluation. So Sri Lanka is a signatory to international health regulations which came into effect as mentioned earlier in 2007. So from the 2017 JAE, actually our quarantine unit and also the EPID unit and the WHO, we had to identify relevant stakeholders for 19 technical areas. So risk communication is one of them. So these stakeholders were involved in the joint external evaluation and there was a report. If you go to the website, just type on JAE Sri Lanka 2017, you can download this report. So initially, we have educated our stakeholders on how to conduct this. So during the evaluation, external resource personnel came from other countries and we had to show the documentation. As Amanti said, we have to show the document. Just the verbal things are not taken. Letters or circular, the printed documents, we have to give a proof. So in the joint evaluation tool, there's a scoring system from no capacity to sustainable capacity. Depending on the technical area, these areas used to, now if you go to the website, you can see the joint external evaluation tools. So currently we use the 3rd edition, earlier we used the 1st edition. So Sri Lankan scores during first joint evaluation, I don't think that you can see this properly, but you can download this from the website, WHO website. So out of 5, we got the scores. Usually for immunization, we got 5 out of 5. And I can remember Dr. Bhattu presented during the first joint external evaluation, they got 5 for internal and partner communication and coordination section. Other areas, they got different scores ranging from 2 to 4, right? So during this 2017 first JAE, these were the scores and there were some recommendations for priority actions. develop a consolidated risk communication plan that brings together existing policies, protocols and procedures. So this paved the way to preparation of the risk communication strategic plan. So others were increased monitoring and outreach through social media, develop a sector-wide training program that includes regular seminars and refresher courses for risk communications and standard training for staff, including surge capacity of staff. Review the feasibility of developing a formal network for risk communication that includes stakeholders, partners and surge capacity staff from all sectors. Actually, this scoring was given after discussing with the relevant stakeholders by the WHO. So after the first joint external evaluation, stakeholders prepared the National Action Plan for Health Security 2019 to 2023. So relevant stakeholders, depending on their priority areas for action, they submitted the activities to be conducted within these 5 years. Some activities in NAPS are routine and some are already identified to be implemented. Some activities are newly added depending on the priority recommendations. So this National Action Plan now from 2019 to 2023, and you can download it from the WHO website if you need. So now second joint external evaluation was conducted in September 2023 using the third edition of Joint External Evaluation tool. There are now under 4 areas the capacities are categorized: prevent, detect, respond and IHR related hazards and points of entry and border health. So under prevent, the legal instruments, financing, IHR coordination, national IHR focal point functions and advocacy, antimicrobial resistance, zoonotic disease, food safety, biosafety and biosecurity, immunization. Under prevent. Under detect, national laboratory system, surveillance, human resources. So these are the capacity areas. Respond, health emergency management, linking public health and security authorities, health services provision, infection prevention and control, risk communication and community engagement. Under IHR related hazards and points of entry and border health, chemical events and radiation emergencies. If you see these capacities, not only health is involved. So there are several sectors like radiation emergency, Sri Lanka Atomic Energy Regulatory Council and Atomic Energy Board. So lot of other stakeholders. For an example, linking public health and security authorities. So we have to work anyway. During COVID, we work with them. So lot of stakeholders were involved. In the first joint external evaluation, there was no separate section on infection prevention and control. This was newly added to third edition. So what we did was we identified the main stakeholders and we asked them to identify other relevant stakeholders. For an example, for legal instruments, we have identified our legal unit as well as the DDG PHS1. But this is not only the health issues. They have to incorporate the other sectors. For an example, for zoonotic diseases, the Department of Animal Production and Health is involved. The Central Environment Authority is involved for chemical events. And radiation, the Atomic Energy Regulatory Council. So they have, our main stakeholder had to incorporate them. As like for risk communication and community engagement, I know to prepare this, the Health Promotion Bureau involved a lot of other stakeholders outside health. So they got the other sectors' views to incorporate into this National Strategic Plan. So our quarantine unit is involved with the IHR coordination, national focal point functions and advocacy as well as the points of entry section. So EPID unit is involved for surveillance and also the immunization sector. So DDGLS involved with antimicrobial resistance. I am giving examples. So lot of other stakeholders were involved in like discussing with the WHO to get the scores during joint external evaluation. This is the second JE. So a lot of stakeholders were involved, but not only these people, other several days we conducted during 5 days. So lot of others were also involved. This is the day one photo. So I mentioned about the IHR monitoring. One method is joint external evaluation. That is not a mandatory thing, that is a voluntary thing. Mandatory one is the state party annual reporting. That is our stakeholders, they fill the document and we discuss and submit to WHO. So this is the tool. In that state party annual reporting, there are 15 capacity areas. Unlike in JE, there were 19 capacity areas. And here, that is because the laboratory sector is amalgamated. In the JE, there are 3 separate areas related to laboratory: biosafety, biosecurity, Asian laboratory system, antimicrobial resistance. So this is in one area. So when we consider the sparse scores in Sierra region, in 2022, this is the Sierra region one, risk communication average is 75%. We give a percent score. So Sri Lanka, 2022, risk communication average is 80%. So this score is considered in sustainable development goals under goal 3, that is ensure health lives and promote well-being for all at all ages. So as this is included in sustainable development goals, we are audited through the general audit. So they are asking why we have not done these activities, why the score is less. Anyway, the average score was 66%. That is fairly okay. The 2021, this is the 2022, the Sierra score was 68%, our country score was 66%, but the global score also was 66%. So this year also we are conducting and we are disseminating the state party annual reporting tool to other sectors to fill. So when we compare the state party annual reporting scores, the Sri Lanka in 2022 got lesser scores for infection prevention and control because they didn't have some plans, the documented plan. So anyway, they have to prepare those plans. During the JE also, joint external evaluation, this was evaluated and they have mentioned, still we didn't get the second report. So then we have to prepare the national action plan for next 5 years. So usually JE is conducted within like once in every 5 years. So during the state party annual reporting tool, once we disseminate the tool, we ask the relevant stakeholders to fill and they fill and send, then we have a discussion and finalize the scores and we are sending to WHO annually. So I told you about 4 methods of evaluating, that is joint external evaluation, state party annual reporting, another one is after action reviews and simulation exercises. So after action reviews and simulation exercises are voluntary instruments that help countries to assess their operational capacity for public health preparedness and response. They provide functional assessments and play a key role in identifying strengths and gaps in the status and implementation of IHR capacities. They can be used to review, validate or test the capacities found or reported by other IHR monitoring evaluation instruments. For an example, by looking at how effective a program or system is versus the extent to which relevant policies are in place. Usually, I know hospitals are conducting basically the drills, one of the simulation exercises. Even during our small ages, at schools we conducted drills, rehearsals. Those things are under simulation exercises. So during after action review or simulation exercise, at least one of the capacities review. For an example, we can review a chemical event incident. Right? Risk communication, suppose during the Nipah virus, lot of people ask why don't we block people, why don't we check people coming to our country. So Health Promotion Bureau did a lot of things through their social media and through their websites. But we can test a disease like, suppose yellow fever coming to our country. How we can have a simulation exercise for that. The ideal timing for after action review is within 3 months after the event. But during COVID, it was like it extended to a long period. So we did an interaction review for COVID-19. So some simulation exercises conducted. Lot of stakeholders are doing simulation exercises, but they don't report. So when WHO comes for the review, we have to show the reports. So I know forces are doing lot of simulation exercise, but with the assistance of Disaster Preparedness and Response Unit in our Ministry of Health, we did beirut-like explosion in Colombo Harbour, involvement of several sectors. Radiation emergency simulation exercise at points of entry was done in 2023. Every year, 10 to 15 hospital drills are conducted. Every year, nutrition in emergencies, one-day simulation exercise is conducted by PGM, disaster management and nutrition emergency trainees. So, health sector contributes to annual tsunami drills conducted by Disaster Management Center. As I mentioned, not only the health sector, other sectors are also conducting simulation exercises. So, there are 4 types of simulation exercises. One is the tabletop exercise, where we can give an event and discuss in a meeting like this. And we can have a drill, then functional exercise, little bit involving the other sectors. Suppose if a yellow fever patient is coming to our country, we can involve the IDH and other sectors as well, where it is incorporated into the drill. Then the full scale exercise. Suppose some milk incident happened in other countries, it's coming to our country, so we can act like that. It's a full scale exercise. So some after action reviews conducted were review of health sector response to Easter Sunday attacks in Sri Lanka in 2019. So with the assistance of Disaster Preparedness of Response Division, we conducted this actually involving not only the health sector, 1990 forces. So we conducted this after action review within 3 months after the incident. Then, as mentioned earlier, interaction review was conducted for COVID-19 because we couldn't wait for a longer period to conduct the after action review. So what are the challenges of IHR implementation? There's a multi-sector engagement and communication, not only the Ministry of Health. We have to work with several other sectors. So let's priority at each level. For an example, Department of Animal Production and Health. So they denotes the production and health, the animal health. So they are involved with that. But now they are working with us, with the health sector very well, to conduct these activities, the priority areas mentioned in Joint External Evaluation report. The 2000 report we are expecting the second report. Limited infrastructure at each level. Staff issues, other like computer or other funding sources, so we have the limited resources. Legislative compatibility. As I mentioned, even though the quarantine unit and EPID unit are national focal points, we wanted to incorporate into our legislative system. Still, we couldn't do that. Limited laboratory infrastructure, specifically labs need to broad spectrum diagnosis for rare diseases and common regions. Not only the health sector laboratories, agriculture, plant sector and other labs. So this is a continuous stakeholder engagement and partnership are extremely important for successful implementation for IHR in the country. No single institution can implement IHR alone. So thank you.
Thank you, Madam. Ladies and gentlemen, with that, we have almost come to the end of this wonderful ceremony. I would like to call upon Dr. Amanti, Consultant Committee Physician and the Unit Head of the Risk Communication Unit at the Health Promotion Bureau to propose the vote of thanks.
I would like to thank each and every one of you, so especially the team that made this all possible, Secretary Health, who could not attend due to urgent meeting commitment today. Then our Additional Secretary Public Health Services, Dr. Lakshmi Somatunga, who went out of her way to somehow come to our meeting today. A very special thank you. Then to our Director General of Health Services also, who could not come due to pressing other meetings. Our Deputy Director General Public Health Services, Dr. Susie Pereira. Then to our WHO representatives and WHO team, who has been always very supportive and who has been with us all the way, Dr. Shalala Amadova, Dr. Samira Hevage, who has been so supportive, and we have been in constant contact during this whole process. Then I must especially thank the external stakeholders who have come all the way here from other ministries, academia, etc., whose contribution and stakeholdership in this is extremely important, not only for this launch. They have been with us all the way, even in developing the strategic plan. Then of course, our health teams, all our the consultants, our medical officers, colleagues who have come from the provinces, the districts, gone out of their way. I know it's a very difficult time, there are many pressing needs, so a big thank you to all of you who have come. And of course, to the Health Promotion Bureau team, without whom none of this would have been possible. The total dedication and commitment of all the support of all our CCPs, all our doctors, our AV unit. I know most of you didn't sleep last night. We have all been working very hard, so a very special thank you to all of you, our DEOs. And a very special thank you to my team members. I know Dr. Natasha is not well, but she has gone so much out of her way to support with this. Then my former team members also who are here today. Very special thank you to all of you. You all have also all supported this and come. And of course, the community-based organizations, Dr. Vinya, thank you so much for coming and gracing the occasion. Once again, it's not only this launch, but all the other meetings and other ventures in which you all have worked collaboratively with us. And of course, Dr. Sampatha also from academia, same. Thank you so much. So I won't be calling everybody by name because I'm sure I will miss so many of you, but it is extremely valued, your presence and contribution, not only today, but throughout this whole process. And thank you very much to all of you for taking the time to grace this occasion and make this a very memorable and beautiful day and experience. And I really hope that we will all continue working together to implement this. Thank you very much.
Thank you, Madam. With that, we have reached the conclusion of this ceremony. Ladies and gentlemen, it's our pleasure to invite all of you to join us for lunch. We would like to thank all of you for enriching our ceremony with your presence. Thank you and have a wonderful day.
Kok ana nih?